It's a beautiful morning right here in the city of Enugu State. Good morning, everyone, and welcome to the Glaucoma Awareness Program right here on Solid 100.9 FM. My name is Chibika James, and this is the week 34 of the Touch Glaucoma Awareness Radio Program. And today's topic is testing for glaucoma. Testing for glaucoma. Right, and joining us this morning in having this discussion is our distinguished guest, Professor Nkirikiza Caraway. She is a renowned ophthalmologist and a public health advocate, and also a consultant right there at the Isut Teaching Hospital, Parkland, Enugu, and governor representing Africa World Glaucoma Association Board of Governors. Ma'am, your title. How do you manage all of this? Good morning and good to have you, ma'am.
Yeah, good morning. It's always delightful to be here. Thank you.
All right, and we are also pleased to have you here as well. So today we'll focus on the crucial aspect of eye health, and that is testing for glaucoma. And if you have been a part of this program often, you would know that glaucoma is often called the silent thief of sight. It is one of the leading causes of irreversible blindness worldwide. This one is not only Nigeria or worldwide. Now, what makes it particularly dangerous is that many people don't even realize that they have it until significant vision loss has occurred. Early detection through proper testing is therefore very vital. And that's why we'll be having this discussion today about testing for glaucoma. So please, I implore you, get your writing materials. Some might say that I don't have any eye problem. This discussion do not concern me. No. It concerns you as well. So please stay tuned as we learn how to protect our eyes, detect glaucoma early, and possibly save our sight. Prof, let's dive into this discussion properly. Okay. Every time we always try to refresh the memories of our listeners, because it's not the listeners who we had last week that will continue with us this week. I'm sure there are some persons listening for the very first time. Let's start with the basic. Okay, what exactly is glaucoma, and why is it often described as the silent thief of sight? I know I talked about it, but then give us the professional aspect of it.
Thank you very much, Chibike. Your unprofessional definition of glaucoma was apt.
Great.
It was wonderful, and the only thing is that it's actually the leading cause of irreversible blindness.
The leading cause.
Yeah. So what we're saying is that if glaucoma gets you blind, only God can reverse it.
Wow.
As far as science is concerned, we don't have a solution yet. So we are advocating, creating awareness so that you don't let glaucoma blind you. And like you mentioned earlier, those who have glaucoma don't know that they have it. In fact, in the last survey that we did in Nigeria, almost 20 years ago, about 95% of those who had glaucoma did not know that they had glaucoma. So only about 5% of those who had it knew that they had it. I mean, that's crazy. That's scary. So in other words, as you are sitting there listening to me, you might have glaucoma and you don't know. In the speaking that came on earlier, he said that don't wait for symptoms. And that's what we are also saying. Don't wait for symptoms. So how will I know if I have glaucoma? Because I'm seeing well. Exactly. Go and have your eyes checked, and that's what we want to talk about today.
Okay.
So I was saying that. So just to answer your question, glaucoma actually is, if I want to give a professional definition, we say it's a progressive optic neuropathy. Okay, that has a characteristic appearance damage to the optic nerve head and visual field changes. Now, let me break it down to the layman.
Okay.
Now, it's a when we say progressive, it means that it's a continuously damaging disease that damages the nerve for vision.
Wow.
So it's a disease that continuously damages the nerve for sight until it has completely damaged.
And it does this silently.
And it does it silently.
Wow.
And but it has a characteristic way it damages, it causes that damage, and that's why we can be able to see it and say, ah, no, this is glaucoma. You know, and it does so silently. Now, how it does it is that it starts damaging the way somebody sees from the periphery, from the outside. So assuming the way you see, if you stretch out your hands both ways, is that wide. So it starts damaging it from there.
Wow.
And reducing it gradually
Wow.
to middle. Okay, so but because it does so slowly, the person who is suffering it does not know that the how wide they are seeing is reducing. Okay, so and even before it starts showing up in reducing how wide you see, it has already started damaging the nerves. You know, so you can see somebody who is seeing 6/6. You know, 6/6 is normal vision, or 20/20. Yet, the person 90% of their nerves are damaged. So somebody's vision can be reduced like looking through a straw, and we call that tunnel vision. And the person will not know that they have any problem, because when they look through that straw, they can see 6/6, and so they think they are normal. So the person, as you are sitting with me here, you know, is not your portion.
Amen.
You know, as we always say, let's go and check and be sure that it hasn't, it's really not your portion. You get me?
Yeah.
You know, so you can be in your office that people say, but nothing was wrong with me. Then suddenly overnight, I just got blind. It didn't happen overnight. Over 30% of our patients who come in, one eye is already blind and they didn't know until that remaining eye gets affected, and they now say, I didn't know nothing. I was seeing very well. Okay, and just overnight. So that's what we are saying, that we have a silent thief of sight, and it doesn't respect age. It doesn't respect color. Color as per whether it affects everybody worldwide, but it even affects the blacks more. And when you come to Nigeria, it affects the Igbos more.
Wow.
You know, so are you listening? Are you African? Are you black? It affects those who are 40 years and above more. You know, so place yourself, and then you know that you need to do this eye check.
All right. Let's now really talk about these testing for glaucoma, because we cannot overemphasize the importance of testing. All right. Let's start with what glaucoma testing is all about. Can you explain to us?
All right. Now, what we do in glaucoma testing, there are different tests that are done to find out whether there's glaucoma or not.
Okay.
And then when there's glaucoma, the type of glaucoma, because that helps
us.
Oh,
so it has different types.
It has different
types. Like how many?
Well, it has two major types, what we call open angle or closed angle. Okay. So so there are different types of groupings, but this is the general one.
All right.
Now, so we need to do this test to find out if glaucoma is there, to the stage of glaucoma, because it could be mild, it could be moderate, it could be advanced. Okay. Then apart from that, the type, because all that affects the decision of the doctor to treat or not to treat, and if to treat, what type of treatment is best. So these testings are very important. The first one we do is we examine the eye, and I must say that none of these testings are painful. They are not painful. They are not invasive. Invasive is like nobody is going to put something into your body. Okay, so it's to examine the eye. So the doctor examines your eye. The ophthalmologist examines your eye, and what are they examining? There are different things that are being examined, but the most important that being examined is the nerve head. Remember, we said that glaucoma damages the nerve for vision. So when you look into the eye, you can see the nerve head, and that is where the damage occurs. So the doctor looks in and to see the nerve head. Remember that I said in the definition that there's a characteristic way it damages the nerve.
Yeah.
So when the doctor looks in, they know whether there is a damage going on. That's one. Then the second thing we do is to do pressure, eye pressure. We check the eye pressure. Now, for the more common type of glaucoma, the eye pressures are raised. But their glaucoma can happen in the presence of normal eye pressures. So, and in the treatment of glaucoma, the major thing we do, no matter which form of treatment, is to bring the eye pressure down. And so we need to know what the eye pressure is. We need to know, is it a high pressure type or is it a normal pressure type? So your eye pressures must be tested. If you go to see any eye doctor at any time, to see any ophthalmologist, they will check your eye pressure. If for any reason it's not checked, please ask, please, what are my eye pressures? They must, if you go for glaucoma testing, your eye pressures must be checked. Then the third thing we do is what we call visual field. Okay, visual field is a test to see, remember, to see how wide you're seeing. Remember I said that glaucoma, when it starts reducing how wide you see. Okay, so sometimes you're still seeing wide, but there are pockets of areas of damage. So this test detects how wide you're seeing. All right, so, and it's called the central visual field. All right, and then we also have what we call pachymetry. Pachymetry, another name for it is central corneal thickness. Okay, so there's an instrument used to touch the front of the eye to check how thick that front of the eye is, called cornea. And so when we say central corneal thickness, to check the thickness of the cornea in the central part. Now that information is very important, because if the cornea has a range of thickness, if that is normal, if that cornea is thin, when you check the eye pressure, it gives you a falsely low pressure. And you will think, oh, my pressure is low.
Yeah.
But it's a deceptive value. If the cornea is also thick, it gives a falsely high value. And you might think, oh, I have high pressure, when really you don't have high pressure. And also, if the cornea is found to be thin, is a risk factor for developing glaucoma. Assuming you don't have it now, is a added risk factor for developing glaucoma. And if you have glaucoma already and your cornea is thin, is a risk factor that it will progress faster. So that is one test that we do. Then there's another test we do, which we call the OCT. Okay, so which the full name is optical coherence tomography. Okay. But in short, we just call it OCT. It's like we do CT scan of the brain, of the or MRI. Yeah, that is similar to that.
Okay.
So what does it do? It analyzes the nerve layers inside the eye. It analyzes the nerve cells, the nerve layers. So remember I mentioned at the beginning that before the damage shows in the visual field, that damage has already started. Now, that OCT is what will show you when damage starts in the eye before it even shows up in the visual field. Okay, so it's a very important test we do now for any modern practice or in glaucoma care. OCT is done because occasionally there are things that look like glaucoma and yet they are not glaucoma. And sometimes some eyes will look as though they don't have glaucoma,
But
yet
they do.
You know, so that OCT is a clincher, and it helps to the doctor to sort out those few differences and also to determine the extent and monitor more closely the progression of damage. Because since it takes a little more time before it shows up in the visual field, so the OCT is a tool that helps you to monitor it very closely. So then that's the highbrow of our tests in glaucoma care.
You've mentioned all these things, okay, and someone might just be sitting at the comfort of their home listening, and you're talking about all the things they need to do to the eye, put in the eye. Is it not painful?
Yeah.
Because even me, with all this, you say to carry something that tricky server, I'll be afraid. And someone that will say, okay, this is interesting, let me go for testing. Yeah, not this thing, the person might feel, God, I don't want to go put my eyes through that stress.
No, most of them are not. For instance, they examine the eye is some light that is shown into the eye. The eyeball is not touched. Okay, the visual field, you just put your chin on a machine and you click what you're told what to click. If you see some light, what to do, you just click a button. So your eyes are not touched. The OCT, the same thing. The only one that's your eye, something touches your eye, is the pressure. Okay, pressure taking. There are even some machines that are non-contact. Okay, that the pressure taking, but before your eye is touched, usually anesthetic drops are put inside the eye. Okay, so meaning what anesthesia does is to numb the surface of the eye, so you don't feel anything. So that's little instrument touches the cornea, and before you know it, the pressure is checked.
So if a person now goes for testing,
yes,
and the diagnosis afterwards that your eyes is in perfect condition, can the person go home and smile and say, okay, you know what, I'm clean, no problem, let me live my life the way I want to live it?
Yes, you are free to go home, definitely, and feel good.
Okay.
But we'll require you to check again the following
So
year.
what is the duration, the time frame? How often should one test his or her eyes?
We advise once you're 30 and above, check every year.
Once you're 30.
And
so for
above,
someone who is
and
below?
African.
Okay, someone who is below?
Yeah, you can check every 2 to 5 years.
Okay.
But if there is glaucoma in your family, because the people who have glaucoma in their family history, they are more likely, they are at greater risk. Okay, so we advise, check. Because glaucoma starts far earlier in the African and runs a more aggressive course.
I'm glad you talk about early. Okay, can children also go for this testing as well?
Yes, we advise if there's a family history, 10 years and above, begin to check. If there's a family history, begin to check. Sometimes we've seen children, young people in their 20s, and they're totally blind from glaucoma. Now, there's one more test I would like to mention.
Okay.
Which, I was talking about, we do different tests for different reasons. There's a test that helps us to know which type of glaucoma it is.
Okay.
And that test is called gonioscopy.
Gonioscopy. Okay, gonioscopy.
Yeah. So it helps us to know, is this an open angle? Is it a closed angle glaucoma? Because treatments can differ. Okay, so and in that test, there's a little instrument that is put on the eye. And before that is put, some drops would have been put on the eye that will numb the surface of the eye. So it doesn't cause pain. So you just place that instrument on top and you do the examination on the machine, and so with that you know whether it's a closed angle or an open angle.
Okay. Looking at this testing, all right. Now let's fantasize a little bit.
Okay.
Now, if someone tests positive for glaucoma,
Yeah.
what are the next step? Because such a thing, person mind, in mind would have skyrocket and say, "Hey, this thing that I've been hearing about, I have it."
That's
So,
right.
what next for a person if it's he or she tests positive for glaucoma?
Okay. When you say the way you say test positive, it's as though you know so we rather say it's found to have
Okay.
or
Well,
diagnosed to have.
your mind will be, hey, Jesus.
So yeah, it's sometimes really, especially if somebody has heard about what glaucoma is or came to check and was found to have, it can be scary for the person. Some we say, so I'm going to go blind. No, a diagnosis of glaucoma does not equate to glaucoma blindness. And that's why we say go for glaucoma testing. Please don't wait for symptoms, because you will not get any until it's about to blind you. So don't wait. When you are still seeing well, go and test for glaucoma. Now, when it is found early, it is so much easier to treat and so much cheaper. Isn't it better to find it early then?
It is.
The way I usually see it is, assuming as we are in this room, we see a little snake, we will all run to kill it. But if you see a big snake in this place, most of us, if not all, we will run
out. Yeah.
So that's how it is. If you see early glaucoma, it's so much easier to handle. There are simple, easy ways to treat glaucoma, to handle it. Now remember that glaucoma is not cured the way, like, I had malaria and I took malaria.
So once it's there, it's there for life.
Once it's there, it's there for life.
Just to manage.
So you manage it and hold it down.
Ah.
Okay, so we either do what we call laser, or we do drops, or we do surgery. And these three ways of treating glaucoma, their aim is to bring the eye pressures down to a level where further damage will not occur. So if it hasn't started affecting how you see, the glaucoma can be arrested, okay, such that you can preserve your vision. So the aim is to preserve your visual function. Okay? And so there's, like I mentioned, for laser, for instance, if you're going to be treated with laser, there are different types of lasers. There's the laser that is used for open angle glaucoma. And most of our people have open angle glaucoma. Okay? And that laser is a very safe and easy treatment. It's a walk-in, walk-out procedure. Meaning you can finish it and go back to your office. Your eyes are not covered. There's no treatment you're put on after that. We call it selective laser trabeculoplasty, in brief, SLT. It's a very safe laser. And in developed countries, it's their first go-to treatment before drops now. Because it's safe. There's also a type of laser we use for closed angle, but it's not all types of closed angles that responds to that laser. Now, if the glaucoma is picked early, okay, it is more likely to respond. The stage of that closed angle is more likely to respond to that laser treatment. Laser treatments are easy go to treatments. But the earlier you are found, the better. All right, then there's medication. Now, there are different categories of medications, like about 5-6 categories
All right.
of medications. Now, if glaucoma is found early, the pressure could be arrested or gotten to the right level with just one drop.
Just one.
With just one drop. But if it has become advanced, you might need as much as 4 types of medications.
Whoa.
And it might still not be enough. So that's why I say that picking glaucoma early is far cheaper to treat. Now, the third path is surgery. Surgery is usually preserved for advanced cases, or if you see glaucoma in the young. Once you see glaucoma in young people, the best thing to do is surgery. Okay? Because they won't be able to manage drops. If it's not advanced, the child has grown into a young adult, you could do the laser we talked about. Okay, but you keep a close monitor on the patient.
Okay, walk us through the surgery part. How is it done?
No, sometimes when you say surgery,
yeah, that's why. Is it that you remove my eyes? I got another eyes to put there.
Exactly. Sometimes some people say, "Hey, surgery." No. Because in their imagination they think they will bring out my eye, put it on the table, work on it, and then we'll put it. But what if he's not able to fix my? But no, that's not how we do surgery. We don't bring out the eye in surgery.
Okay.
Yeah. Most of the surgeries, we give a little injection around the eye to numb.
Around?
Yes.
Okay.
Yeah. To numb the eye so that you don't feel anything while we are working on the eye. So you lie down, we work on the eye with you there without bringing it out. So now for glaucoma, what do? We create a little channel for fluid inside the eye to go out into the body. Okay, so that channel, with the fluid going out, the eye pressure comes down. Because what causes most of the glaucomas to have raised pressure is that the channel through which fluid leaves the eye, that's inside we are not talking of the external tears. There's fluid inside the eye. The channel that it goes out of the eye gets blocked. Okay, so all this other treatment is either to reduce how much the fluid is produced or to help it going out of the eye. So in surgery, we create a channel for the fluid to go out. Okay, and and we cover up the space. Where we work, you don't see it when you look at the eye. Okay, so it's cool.
All right.
Yeah.
Well, ladies and gentlemen, we are still discussing, and today we are talking testing for glaucoma. And if you're just joining, well, you have missed quite a lot because we do have our distinguished guest, Professor Nkiru Kizo Akerewe, who is a consultant ophthalmologist, Institute Teaching Hospital, Park Lane, Enugu, and she is governor representing Africa World Glaucoma Association Board of Governors. The numbers to call are 0704 550 2840. You can also call 0909 771 1009 as well as 0902 311 1009. Okay, those are the numbers for you to be part of the discussion this morning. I will implore you, please, once you get through, stick to the discussion and keep your conversation as precise as possible. Thank you very much. Hello, good morning to you.
Hello, good morning.
Yes, good morning.
Yeah, this is Mr. Botna calling from Abakaliki.
Welcome, Mr. Ogbonna.
Yeah, the professor said that Africans are more liable to suffer from glaucoma. And she further breaks it down to Igbos.
Mm.
I want to know why the Igbos are the most likely people to get glaucoma.
All right. Thank you very much, Mr. Ogbonna, saying that he wants to know why the Igbos are the people, the region that have higher chances of all of this. Let's still take more calls. 0704550 and yes 0902-311-1009. Hello, good morning to you. Hello. Yes, good morning.
Good morning, Doc. Good morning.
Yeah, good morning.
Good morning.
Madam, good morning.
Good morning.
Doc, I was your patient before.
What is your name?
So I was your patient, sir. I've come 3 times.
What's your name, sir?
My name is Agu J. Philos.
All right, Mr. Agu. Go on.
Yes. Please, my daughter has eye problem. He was watching television in a one-room apartment, so the eyeglass reflected her eyes. So since then, she has been wearing glasses. Since the secondary school to that day, she has finished now. Is there any way they can do operation and then you will not start using the glass again? That's the first one. The second one, I was in a clinic. I saw the 2 doctors before I could get to you. And he treated me very, very, very fine. I was very happy. Upon all the tests I went to your clinic. So he told me to continue to buy the best thing he gave me. But since then, I have dropped the medicine. I'm now applying organic eye drop. And each time I open my eye, I use my eye, I open the upper lid, and the one that they did operation. The reflection of the sun will just come into my eyes and everywhere be dark. Then if I leave it more time, it will be white again. So since then, I have not been seen anywhere. That retinal detachment is there any treatment at all that can be used. Thank you very much.
All right. Thank you, Doc. Prof, sorry.
We're all doctors.
Okay.
Okay, let me take. I don't quite fully understand the second.
They're saying that he was taking an organic eye drop and he doesn't. Right now, if he gets to see something, reflection is going blur, and later, after a few minutes, it comes back clearer again.
All right. Okay, so let me start with him.
Okay.
Yeah, that's Mr. Ago Theophilos. He said something.
The daughter.
Yeah, the daughter about glasses. Yes, there's some surgery you can do that can be done, especially that is to stop someone from using glasses, especially if someone is short-sighted, but usually if it is very high short-sightedness, okay, then some surgery can be done to reverse it.
Okay.
But usually not in young people who are still growing. Okay, it's usually in adults who are well into beyond the growing stage. Okay, so I want to say that there's nothing wrong in wearing glasses. For young people, they can, or even for older people, just find a nice frame that fits the face, adds to it, and you look like a professor, and wear glasses. It's nice. One that fits the face. So it's not a crime. Yeah, sometimes when you tell parents, oh, your child will need glasses, they say, God forbid, at this age, no, there's nothing. It's just the way the eye was structured when the child came out. Some eyes are short-sighted, some eyes are long-sighted. So it's terrible if a child is not seeing well, and you refuse the child from wearing glasses. And when you do that, especially in a stage where the eyes are learning to see, because the eyes learn to see by seeing. So if the eyes don't see well when the child is a child, then the vision will not develop beyond the much they have seen.
Yeah.
Okay, so please let the child be, and until they become full adults. Then if it's a short-sighted type, surgery could be done. Then for his own matter, I don't know if it is that he has retinal detachment from what he said.
Yeah.
Retinal detachment usually is an emergency, requires emergency surgery. If it's an old retinal detachment, there's nothing that can be done about it to restore vision. Now, but if you have had retinal detachment before, then the other eye is also at risk.
Whoa.
Yeah, so you need to have regular eye examinations, okay, to detect if there are predisposing, that is, conditions that could lead to it. Because usually those conditions exist in the other eye before it now develops retinal detachment. So if you have had one before, that other eye needs to be properly examined 1 to twice a year, so that if those things that lead to it are there, then laser treatment could be done, and that is like eye saving. Okay, so that's the advice I can give to Mr. Ago.
Okay.
Then for Mr. Obunna,
Yeah. Why Igbos?
yeah, why Igbos are more predisposed? It's majorly a genetic thing, because in the survey we did in Nigeria, Igbos were found, no matter where they were in any part of the country, they were found to have more glaucomas than other people. So with the analysis, what we call multivariate analysis, Igbo tribe was now a risk factor. So we are doing a lot of genetic work study now. Okay, so the particular maybe genes that are responsible, we've not reached that stage yet. We are still at the level of Africa. Before, genetic studies were just done among the whites. So recently we've done genetic studies in Africa to isolate the genes. And for now, we found that the genes responsible for glaucoma in Africans are quite different from the ones responsible for the Caucasian glaucoma.
Right.
And ours is more aggressive.
All right, ours is more aggressive. Let's go back and take more calls. Right here. Hello, good morning to you.
Yeah, good morning, Chile.
Yes, morning.
Please, if people know how
Your name,
how
sir?
we talk to make this call,
Your name,
you
sir.
will be ignoring some of our details that come in, please, because we find it difficult to even.
Hello? Oh, come on. I was not even getting what you were saying. But let's take another call. Maybe you call us back. Hello, good morning.
Good morning, Chibike.
Yes, morning.
And the prof in the studio.
Yeah, good morning.
So I want to direct this. My name is Osman, the chemistry teacher.
Welcome.
I'm calling from Olo in the Zagro government area.
Good to have
So I
you.
want to ask the prof this question. Prof, why is the probability that glaucoma patient that undergoes surgery will later become blind in this country is 50%? But it is not so in foreign countries. Does it mean that the ophthalmologists, optometrists, opticians, and those ones that we have in the treatment of eyes are not knowledgeable enough, or they do not have enough facilities to handle glaucoma surgery in this country?
All right.
Thank you very much.
All right, Osmond, thank you very much. Let's still add one more question to that. 0704-550-2840, 0909-771-1009, and yes, 0902-311-1009. Hello, morning.
Hello, good morning.
Yes, morning to you.
Morning, Prof.
Yeah, good morning.
Yeah, my name is Mr. Awa.
Mr. Awa, good to have you.
I'm calling from Balabaras.
Welcome.
Yeah. I want to find out this glaucoma, when somebody has been affected,
already. And then, what is the way to make it for the person to continue managing what is material?
Mr. Awa, we are not getting you. Can you come clear?
Somebody has their community.
Okay.
And then how can you manage it as it's not curable? How can one manage it maybe normal?
All right. No problem. Thank you, Mr. Awa. Let's add one more, Prof. Hello, good morning.
Yeah, good morning, Chief.
Yes, morning. Can you speak up, please?
My name is Charles. I'm calling from Enugu.
Welcome.
Yes, thank you for bringing up this program most Fridays. Please tell Prof that
she's listening. She's listening. Tell her yourself.
I
said she's listening. Tell her yourself.
Okay, it's all right. Prof, please, affording your medication is very expensive, and affording your facility. We have been there with my daughter, but the cost is too expensive. And coming here to tell us about our eye health and then how to assess your hospital and treatment and facility. And then when we get there, we find out that it's too expensive. So maybe it's only for the rich people. Is there a way you can readjust a little so that you can accommodate the average people? It's too expensive.
All right.
To buy card and then give medication is overly expensive, bro.
Okay. Thank you very much. It's not Prof Hospital, first of all. Me, I know that one is not Prof Hospital. But Prof, you've had the 3 questions.
Yeah. Thank you very much. So Osman asked the third caller said that why do 50% of our patients who do surgery, glaucoma surgery, go blind, and after surgery?
Yeah, in Africa, yeah.
Yeah, and so is asking, is it because the ophthalmologists, optometrists, opticians are not skilled enough, or they don't have the equipment and stuff like that? First of all, I want to say that of the different eye care providers, the only set of people who do surgeries are the ophthalmologists. Okay, so the optometrists majorly help with providing glasses, and the opticians help to fix the glasses. Now, the I don't know where Mr. Osman got his statistics from, because when you talk of statistics, you must have evidence, so I don't think that statistics is right. But now there are, the African eye is more prone to what we call scarring, forming scars after surgery. Okay, and that forming scars after surgery, we seal that hole I spoke of, that channel we open at surgery. Now, a major problem with our people is that they don't go for checkup. Nobody, and in answering that, I'm joining it with Mr. Awa's question, how to manage glaucoma. I mentioned that glaucoma management is for life. But our people want a once and for all thing. So you do surgery, or whether you're medications or you do laser, you must keep going for checkups. You must keep going for your follow-up visits, so that if the pressure starts, there's no treatment for glaucoma that is permanent. But so you keep going for checkup. If the treatment is not working anymore, then something can be done. Now, if scar tissue starts forming after surgery, there's a shape the area of surgery takes. If you went for follow-up, the doctor will see it on time and intervene. But if you don't go again, then you say, I've done surgery. The next time, the pressures might have gone back up and damage continues. Okay? So, and sometimes after glaucoma surgery, the eyes develop cataracts. And if the person goes for checkup, the cataract can be removed. And vision, when the eye develops cataract, vision goes down. And the person can presume, I'm now blind. But it is just because there's a cataract, which if removed, the vision that was there can be restored. So in summary, all I'm saying is that partner with your ophthalmologist in your care. don't stop going for your checkup visits. If you are not satisfied, then you could go and seek another opinion, second opinion. Okay, but don't stop going. Don't stop going.
And self-medication. This one say if I take this one, it's going to work.
And then you try. You know,
And you're mixing native and English together.
Yes, somebody had told us he stopped medication, he's using organic treatment.
Yeah.
I really don't know what that means. You know, so our people say that you don't use what you use in cleaning the ear to clean the eye. In other words, the eyes are precious.
Yeah.
You know, so don't handle it carelessly. You know, so I want to say, in answering Mr. Awa's question, when you are diagnosed with glaucoma, know that your care is for life. Don't do yourself the injustice of stopping to go for your care, thinking that or wishing it away. Don't do that because damage goes on. Okay, and finally, the last caller, you know, talking about
pricing.
Now, there are pricings in different places, okay, depending on what is being offered. For instance, when you go to, I work in Parkley, government subsidizes care because government pays the workers. Okay, so if you go there and you get care, it will be at a cheaper cost than if you go to a private facility. You know, because the private facility, they have to pay their staff, they have to run their bills, they have to run generator, run everything. You know, so that's pricing differ in different places. The important thing is to go to where you can afford and at where you can still see the competent hands. We are not talking in this program for you to come to any particular private. We're educating you on how to care for your eyes. You know, but please, the services that we talk of are also available in Parkland, in the teaching hospital in Parkland.
All right. I'm sorry, we cannot take more calls. Maybe you keep your questions for next week, Friday. And just before we go, okay, I'm sure there are some of you who might be willing to, you know, have conversations more on all of this and more. You can join our glaucoma WhatsApp channel. To do that, all you need do is send glaucoma, GLAUCOMA, GLAUCOMA to the number 0810 435 8093. I'll take it again. 0810 435 8093 on WhatsApp, okay, so that you can be added to the group, the channel, and learn more about glaucoma. Please do not send text message, only DM on WhatsApp. 0810 435 8093. Again, 0810 435 8093. Do not send text message, only DM on WhatsApp, and you will be added to the channel where you get to learn more about glaucoma. Prof, thank you very much.
Thank you very much, if we can.
All right, and that's the wrap on the show. Yes, we'll see you all again next week, Friday. Bye-bye.